It's no secret that the opioid epidemic in America is growing, but how much do you know about what it's like to treat someone who is addicted to opioids? In her new book, Policing Patients, author Liz Chiarello shows us the treatment and surveillance of patients on the front lines of this crisis. And Liz joins me now. Thank you for being here.
Thank you so much for having me.
Yes, so such an important conversation. And you started the book with a bold claim, and that is that the opioid crisis that we've read so much about, we kind of assume that it started with OxyContin and Purdue Pharma, but you say in there that that's not necessarily entirely true. What do you mean by that?
I think it matters where we start telling stories. And the story we keep telling ourselves is this one of an evil drug company that has hooked a nation. And it's not that that story is not true. It's that our country hasn't decided whether we think addiction is a medical problem or a criminal problem. And we've been toggling back and forth for the last 100 years on that question. And so what happened right before OxyContin came out was we had a pain management crisis where patients were dying in pain and couldn't get access to care, to opioid treatment. And so we have to take that into consideration when understanding what happened when Purdue came into the picture.
That is, you explain it so perfectly there. And you say here too that Seattle holds a special place in your heart. Why is that?
It does. When I graduated from college, I'm from Texas.
Okay.
And when I graduated from college, my best friend and I moved to Seattle.
You did?
And lived in her aunt's basement in West Seattle. And I temped. I worked for the Sonics. I worked for King County Disposal, an acute boutique on First Street. So I really got to know the city and just fell in love.
That's amazing. And welcome back. And I understand that you've started your work on pharmacists in Washington. Tell us about that.
I did. So I started out as a reproductive health researcher.
Wow.
I was interested in the conflict around emergency contraception, where some pharmacists were refusing to provide it because they believed that it was an abortifacient. And what happened in Washington was the Board of Pharmacy made a rule about whether or not pharmacists could opt out. Most other states were doing that through the legislature. And so I wanted to understand how social movements impacted professional decision making. And so I came and I interviewed pharmacists and board members and watched their comment period in their town halls and learned a lot about that process.
That's amazing. And you mentioned this a lot in your book, which I hadn't heard about, I'm embarrassed to say. What are prescription drug monitoring programs, and why do you call them Trojan Horse technologies?
You are not alone in not having heard of the PDMP, but a lot of people are being tracked by prescription drug monitoring programs.
Yeah.
They are big data surveillance technologies that track all of the controlled substances, so not just opioids in a state. If people take benzodiazepines for anxiety, what's the sleep medication?
Oh yeah, no. We'll get there. We'll get there.
Okay.
Yes.
But if you take any of those, you're being tracked in this system. And what they do is they compile all of the pharmacy dispensing data. They send it to a third-party vendor. It's called Bamboo Health. They then compile it and create a risk score, and then they feed it back to healthcare providers who can use it to make decisions about patients, and to law enforcement who can use it to make decisions about both patients and providers. So it's a two-tiered surveillance technology, but I call it a Trojan Horse technology because it was designed for law enforcement and it has been handed to healthcare as a gift. But because it's an enforcement technology, even though it's being used in healthcare, it is being used to police patients. And so it actually transforms a lot of the work that physicians and pharmacists are doing in unexpected ways.
Definitely. And you say that addiction and chronic pain are incompletely medicalized. What do you mean when you say that?
Medicine is a hungry institution. It likes to take under its purview things that aren't even necessarily medical, you know. And yet it has held chronic pain and substance use disorder at arm's length. And by that I mean most physicians aren't trained to treat those things. There are very few specialists in those areas. And so it just hasn't become, neither of those have become part of mainstream medicine. And I think healthcare providers also feel comfortable refusing to treat those conditions. Even primary care physicians often refuse to treat chronic pain and substance use disorder, whereas things that are completely medicalized, most doctors know how to do or know who to refer to.
And I thought that was interesting that you think, doctors are probably getting all of this training and physicians about, and actually, in fact, like you mentioned, they don't have all of that information on the past of this crisis. So I just thought that was an interesting tidbit that you mentioned as well. And we want to talk about too, one state over, Oregon, from us. Efforts are being made to decriminalize drugs, but that seems to have failed. What do you think it means that decriminalization and that not working, that it doesn't work?
I think we have to be really careful about the story that we tell ourselves about the Oregon decriminalization efforts. We have been in a war on drugs for 50 years. We have taken strong enforcement strides. We've been trying to stop drugs from coming across our border. We fortified the DEA. We have policed providers. We've done all of these things. And then it was like for 2 seconds, we thought, for about a year or two, we thought maybe we'll decriminalize in Oregon and see how it goes. But Oregon was supposed to be based on the Portugal model, which has been actually extremely successful. But it involves, instead of taking people to prison, you ticket them, and then you give them an opportunity to go to treatment. And you have to fortify the treatment infrastructure to make that possible. And Oregon didn't do that. They gave out the tickets, they stopped criminalizing, but they didn't build out their treatment infrastructure. And a big part of that is because COVID hit, right when they were in the middle of that. So public health was kind of busy. And so I don't think Oregon is a great example of what happens when you decriminalize. We just didn't give it long enough to be effective.
Wow. I could talk about this with you. This is just so interesting and a topic that I feel like we need to talk more about. So thank you so much for being here. And just a reminder, Liz is holding an author event at the Elliott Bay Book Company tonight, Monday, October 14th at 7 p.m. So you can go and meet and see her there.